Welcome, everyone. Thank you for joining us today. Let's give just another minute or two for everyone to join into the webinar, and then we'll start. Hello, everyone, and welcome to our webinar today. Thank you so much for joining us. We're going to be discussing competency-based education, navigating AACN essentials for advanced practice. We're recording this webinar, and it will be posted on the page where you registered. We'll share that link in the chat. Now, it's my pleasure to introduce our presenters for today. Dr. Christy Doherty is the Executive Director of Nursing and iHuman Patients at Kaplan North America. Dr. Doherty is a skilled researcher, valued professor of nursing, experienced clinical nurse, and designer of virtual simulation. She's earned certifications in nursing education, healthcare simulation education, diversity, and inpatient obstetrics. Dr. Doherty has published several books and journal articles and presented nationally and internationally on diverse subjects, such as clinical judgment, mentorship, simulation, and students' engagement in statistics and informatics. Also presenting today, Dr. Maria Ojeda, who will be on the chat with us. She's the Director of Nursing Research at Kaplan North America. She's a licensed and board-certified family nurse practitioner and a dual doctorate, Doctor of Nursing Practice and Doctor of Philosophy in Nursing. She's been involved in conducting nursing and healthcare research for approximately 27 years and has a total of 18 years of experience in nursing education at the undergraduate and graduate levels, as well as the development and presentation of professional continuing education courses. So without further ado, Dr. Doherty, I'll hand it over to you.
Thank you, Anne, for those introductions. Hello, all. Dr. Ojeda and I are very happy that you're attending today. We hope to share some valuable information with you that will assist in your transition journey to competency-based education. If you have any questions along the way, please feel free to put them in the chat. We'll try to answer them as we go along, and we'll address any that are unanswered at the end of the presentation. So let's jump right in. These are the objectives. Today, we're going to define competency-based education. We're going to identify foundational aspects and advantages of CBE. We want to explore the essential assessment framework, compare progression indicators and learning experiences, and examine implementation and evaluation best practices. I want to start with the word competent. What does it mean to be competent? Let's step outside the healthcare arena for a moment and discuss this word in context of an experience that many of us can relate to, riding a bicycle. How exactly do you describe competence in this situation? Look at this picture. Do you see a child in the beginning stages of competency? I see some basic knowledge here about riding a bike. The child appears to know what a bicycle is. They know where to sit, where to place their hands on the handlebar, and where to put their feet on the pedals. And by this picture, it appears they even have the knowledge to propel the bicycle forward. In this case, training wheels are evident and they assist in the learning. But is this a competent bicyclist? What about this picture? The training wheels are gone and the child is learning to balance themselves on the bicycle. With the assistance of another, they're beginning to perfect their skills to ride the bike. But are they competent? What about this picture? We see a culmination of the knowledge about riding a bike and the skills to move it forward. Would you consider this a competent bicyclist? Expert, maybe not, but certainly competence. Can you see any information that indicates an attitude about riding the bike? Well, I do. Look at his face, that big smile, very powerful. In this static picture, we can observe some basic information about knowledge, skills, and attitudes when riding a bike. But before I move away from this picture, look at the parent in the background. That parent is the educator in this situation. Do you think he's proud of the child's progress? I believe that's evident by the huge smile on his face. And do you feel that way as an educator? I do. As an educator, we have immense pride when our learners are able to demonstrate competency. What else can we learn about competence with these pictures? I think it's clear that competence develops over time, it's progressive, and reflects the impact of those internal and external factors and the experiences of the learner. But competency-based education is not new to nurses. We've been assessing KSAs, or those knowledge, skills, and attitudes of our patients and students in our roles as nurses. Think about the newly diagnosed patient with diabetes in your clinical practice. You had to teach about the disease, demonstrate how to administer insulin, and evaluate that teaching with return demonstrations by that patient. Same process in education. When teaching students how to start an IV, we teach the knowledge, demonstrate the skill, and evaluate their competence in completing the task. So as we move forward in this presentation, I want you to reflect on this analogy and realize you have a lot more experience with competency-based education than you may realize. Well, let's start with some basic definitions so we're all on the same page. Competency is an observable ability of a health professional integrating multiple components such as knowledge, skills, values, and attitudes. Because competencies are observable, they can be measured and assessed to document acquisition. Again, see the emphasis on knowledge, skills, and attitudes. Other professional organizations have defined competency-based education. The American Association of Colleges of Nurses defines CBE as a system of instruction, assessment, feedback, self-reflection, and academic reporting that's based on the learner's ability to demonstrate knowledge, skills, and attitudes appropriate to their level of education. Are you seeing the trends in KSAs? The National League for Nursing defines CBE as a learning model that focuses specifically on student outcomes in the form of demonstrating knowledge and skill mastery of identified competencies. And finally, professional journal articles have defined CBE as allowing for a common understanding of the knowledge, skills, and experiences nurse practitioner graduates require for entry to practice, and also provides consistent and uniform expectations for novice nurse practitioners. In this definition, I want to call out the word entry to practice. Do these definitions say the learner has to be an expert to begin their career in nursing? No, they don't. Like the bicycle analogy, they don't have to be ready to ride the bike in the Tour de France bicycle race. They only have to be able to competently propel themselves forward and continue to learn. Benner's novice to expert comes to mind when I read this definition and aligns with CBE, and I will elaborate more on this in a future slide. So what are the drivers to move to competency-based education? I mean, why do we need to change what we've been doing in nursing education? Well, I have a few reasons here. First, the academic nursing to practice gap. Many employers are reporting that new nurses and new practitioners are not equipped to handle the complex health situations that arise in clinical practice. As educators, we believe we're preparing students adequately, but perhaps we need to revisit how we teach and how students learn. What about the exponential growth of knowledge in healthcare? I've been a nurse for almost 35 years, and I've seen dramatic changes in disease process, treatments, and the like. In fact, in 1950, research stated that the wealth of medical knowledge doubled every 50 years. Well, not too concerning, considering that most nurses don't practice for more than 50 years, but very informative. In 1980, it was determined that medical knowledge was doubling every 7 years. In 2010, medical knowledge was doubling every 3.5 years. And most recently in 2020, it's determined that medical knowledge was doubling every 73 days. Now, it is not possible for a learner to take in that amount of information every 73 days. It's evident that we need to teach our nurses how to build on their knowledge, skills, and attitudes in order to care for patients in this ever-changing healthcare environment. Another reason we need to pivot to competency-based education is the number of preventable medical errors. In a research study that came out this year, it was reported that approximately 400,000 hospitalized patients experience preventable medical errors every year, 400,000. It's also estimated that more than 200,000 patient deaths a year can be attributed to preventable medical errors. A really powerful statistic that we can't ignore that drives our need to change how we're preparing the next generation of nurses. Now, the foundation of competency-based education aligns to solving the gaps mentioned on the previous slide. First, students are the center of the learning experience. With CBE, the student determines the acquisition of learning and the timing of their learning journey. If some knowledge or skill needs to be reinforced, it's reinforced when the student needs that information. Performance expectations are clearly delineated. We need a clear set of expectations that an entry-level nurse or nurse practitioner needs to master. Those expectations need to be clearly outlined for education and practice in order to ensure there's not a practice gap. To avoid that situation where nursing practice feels a competency is missing from education of an entry-level practitioner, it needs to be clear in our foundational documents so educators can ensure the competency is being met. Another key component is that CBE measures observable behaviors. Book knowledge is not enough to be prepared for practice. Frequent assessments are key using diverse methodologies. Does a written test indicate a student can start an IV? Have you seen students that don't do well on written tests but have excellent clinical skills? And finally, intentionality of learning. No busy work or assignments that don't align to those foundations. Overall, nursing holds the title of the most trusted profession, so it's essential for programs to produce graduates who demonstrate attainment of competency. Otherwise, a potential perceived lack of experience may erode the established public trust. Well, what are some advantages of competency-based education and curriculum? Well, CBE enhances critical thinking. When you build on information you've already learned, you utilize skills you've already mastered, well, the nurse has increased confidence and competence in their abilities to care for patients in practice. CBE increases engagement and accountability. The student leads their education and the achievement of competency. Remember, they're the center of the learning experience. Faculty are present to facilitate learning and provide additional resources if a student is struggling. And CBE is inclusive. Equity is achieved by fitting the learning to the learning style and the pace that learners from different backgrounds may require. Competency-based curriculums promote long-term learning. The students aren't cramming information before a high-stakes test. They're building their knowledge and skills as they progress through their educational journey. And it connects that education to the professional nursing role. The KSAs in the nursing program align to those real-world tasks that they would be expected to perform. And as a bonus or as a requirement, CBE is endorsed by our accrediting organizations. One more comment about competency-based education that I want to bring up. The fundamentals of CBE indicate that the student sets the pace. There are different pathways to learning and that the pace can be varied. but I want to emphasize what CBE is not. While it lends itself to be a variable time frame for learning, at this point, there is no emphasis on the need to adjust the number of credit hours in a program or other similar concerns. Now, will this happen in the future? I don't know. That's too soon to tell. But at this point, we'll follow the guidelines of our accrediting bodies. So you know what CBE is, but how do we determine the competencies? Well, we don't have to. A standardized framework has been created to share a common language about nursing competencies, promoting clarity. In the past, multiple nursing specialty roles have contributed to the variations in defining core competencies. But it's clear that if health professionals begin to use the exact words with the same meanings, they communicate more effectively and reduce misunderstandings about knowledge, skills, and abilities. I want to emphasize again that CBE is not new. The WHO in 1978 published about CBE and medical education, and our medical professional colleagues have led the way with standardized framework. In addition, many new nursing schools have transitioned to CBE. Western Governors University, founded in 1997, is the largest school in the nation that uses competency-based education exclusively. And the rest of nursing is catching up fast, guided by some foundational documents. The foundational document at the center of this presentation is the AACN Nursing Essentials. They are the core competencies for professional nursing education. The essentials are divided into 10 domains. Knowledge for practice is that comprehensive, evidence-based knowledge from nursing and other disciplines that forms the foundation for safe and effective nursing care. Person-centered care, that is providing care that's respectful of and responsive to individual patient preferences, needs, and values, ensuring that the patient values guide all clinical decisions. Population health, applying principles of public health and nursing to improve health outcomes for diverse populations through disease prevention, health promotion, and addressing health disparities. Scholarships for nursing discipline, that's engaging in continuous learning, research, and the application of an evidence-based practice to advance the nursing profession and improve patient outcomes. Quality and safety, ensuring high standards of care and patient safety through systematic evaluation and continuous improvement of healthcare practices. Interprofessional partnerships, collaborating with other healthcare professionals to provide holistic, coordinated, and patient-centered care across various settings. Systems-based practice, understanding healthcare systems, policy, and financial considerations to deliver efficient, effective, and patient-centered care within that complex healthcare environment. Informatics and healthcare technologies, utilizing technology and informatics to enhance patient care, improve clinical decision-making, and support healthcare delivery systems. Professionalism, that's demonstrating those ethical principles, accountability, and a commitment to the nursing profession, ensuring trust and integrity in all professional activities. And finally, personal, professional, and leadership development. That means engaging in self-reflection and lifelong learning to advance personal and professional growth, fostering leadership skills to influence healthcare outcomes. And the domains are further divided into specific competencies and subcompetencies. Another component of the essentials is that they're separated by level of practice. Level 1 is for entry-level nurses preparing for their initial nursing degree. And level 2 is for advanced level nursing education used to prepare nurses for an advanced practice specialty or an advanced nursing practice role. And to note, when nurses are working towards meeting level 2 requirements, they have already achieved the level 1 competencies. This is a sample of a competency and subcompetency within the first AACN essential domain of knowledge for nursing practice. The gray is the competency, and the white underneath is the subcompetency. Here's another way to break down the components of the essential assessment framework. Competencies outline those knowledge, skills, values, and attitudes that we've already discussed. The subcompetencies outline the observable behaviors that just demonstrate the competency has been achieved. The progression indicators are how the competence is developed and leveled to the learner. And finally, the learning experiences are the formative and summative assessments that are available to determine how a student is gaining ground on mastering the competency. So how do we use the essentials to guide assessment? Well, two types of assessments are required. The first is the cognitive or objective assessment. These assessments focus on what the learners know and what they know how to do. These are considered indirect assessments and are very knowledge-based. I'll give examples on the next slide. The second type of assessment is the behavioral or performance assessment. These focus on what the learners can do with their knowledge. These are direct assessments and demonstrate the higher level of critical thinking and are observable and measurable. Here are some brief examples of cognitive and behavioral assessments. Most cognitive assessments involve testing, classroom tests, or standardized tests. Now, a standardized test with adaptive methods, meaning the question that the student has answered determines the next level of question that's asked, is an ideal assessment method. A clear example of this is the computer adaptive test utilized by the NCLEX exam in the pre-licensure nursing. But behavioral assessments are those active learning strategies that encourage a student to reflect on their learning, analyze their answers, discover, interact, and create components that demonstrate their abilities and their competencies. Miller's Pyramid of Clinical Competence offers a compelling educational theory demonstrating that no single assessment can capture the complexities of clinical competency, and that solely focusing on objective testing of knowledge is insufficient for determining a practitioner's competency in direct patient care. Now, I'm not saying that we should not test the student's knowledge, but we need to do more and determine what they can do. Knowledge-based cognitive assessments do form crucial foundational elements for students' learning. Now, the pyramid illustrates the different levels of competence, starting with the knows at the base, progressing to the does at the peak. This aligns with the idea in CBE that learners should be assessed not just on their knowledge, but on their ability to apply that knowledge in practice. You'll also notice on the right-hand side how movement of the pyramid aligns with Benner's novice to expert methodology. A novice nurse may know, yet an expert nurse can do. This slide demonstrates how learning objectives map to the assessment components of Miller's pyramid. To recap Bloom's taxonomy, remembering is memory of material by recalling facts. Understanding is organizing those facts and stating main ideas. This aligns to the knows level of Miller's pyramid. Applying is solving problems by applying their knowledge in a different way. And this aligns to the knowing how on Miller's pyramid. And analyzing breaks information into parts by identifying the causes and making inferences. Evaluating is where you present and defend an opinion by making a judgment about the information. And these both align to Miller's pyramid of shows how. And finally, creating. Creating is compiling information together in a different way by combining elements in a new pattern or proposing alternative solutions. And this is the top of Miller's pyramid. Scaffolding is important to consider, and scaffolding of the learning is when we align the measurable assessments. Scaffolding is the breaking down of information into those small, manageable chunks and leveling to the ability of the learner. Along the same lines, formative assessments are performed first, followed by the summative assessments. The key to scaffolding is to introduce the material, reinforce the material, then advance the information until that competency is achieved. Now, the next topic I want to discuss is how to align learning experiences to assessments. When all possible, learning experiences should be integrated with the content and experiential. Practical use of information allows for the greatest level of learning. It's important to ensure that assessments include a period of self-awareness and reflection. In simulation in particular, best practice indicate the need for students to reflect on their learning and identify areas of improvement. Again, active and interactive experiences are most engaging. The word development here means that the experiences should be cumulative and aligned over time. Transferable indicates that the experiences must include multiple demonstrations and occur in multiple contexts. So let's work through some of these together. Referring back to Domain 1, Knowledge for Nursing Practice, the competency that indicates the need to demonstrate an understanding of the discipline of nursing's distinct perspective and where shared perspectives exist with other disciplines. The subcompetency we want to focus on is 1.1F, the need to demonstrate the application of nursing science to practice. With this competency and subcompetency, the progression indicators would be that the learner is able to summarize evidence informing practice and demonstrate the specific nurse practitioner characteristics. Learning experience would include perhaps a written assignment describing EBP guidelines for a clinical case study, a group debate on best practices that apply to a case with determined patient goals. And this can be done in person or it can be a virtual meeting. Or developing and documenting an EBP treatment plan for a clinical case. Now, just a note, these are suggestions for progression indicators and learning objectives, but we're not replacing that faculty expertise. So let's look at another example. The domain is number 2, person-centered care. The competency is 2.3, to integrate assessment skills in practice, with a subcompetency of 2.3H, demonstrating that one's practice is informed by comprehensive assessment appropriate to the functional area of advanced practice nursing. Possible progression indicators for this competency and subcompetency include obtaining a comprehensive health history and identifying actual and potential health problems. The learning experiences could be having the students record a video themselves conducting an assessment, or having a group debate over the actual and potential health problems of a patient that was presented in a case study. Now, my favorite, have the students complete a simulation demonstrating the ability to complete a health history. And then, of course, the clinical evaluation of a complex patient observed by a competent preceptor. Other active learning strategies that support CBE include case studies. Research has shown that nurse practitioner students work through patient case studies individually or as a group. They can gain experience with decision making, and it's supported by feedback. Ask Me 3. Now, this is an intentional activity outlined by the Institution for Healthcare Improvement. It's where a case is presented and the learner answers the main 3 questions that would be asked by a patient. And those are, what's my main problem? What do I need to do? And why is it important for me to do this? Guided reflection. I mentioned this earlier. When learners reflect on their experiences, they develop a deeper understanding of their performance and areas of opportunity to grow as a nursing professional. Socratic questions have always been a strong learning strategy. Good questions can inspire learners to question assumptions, explore different perspectives, and articulate the reasoning behind the decisions they made. This aligns with CBE's focus on the learner's ability to demonstrate knowledge. Collaborative learning. We know social interactions influence learning, and when applied to a real world context, enhances clinical thinking. Finally, role modeling and role play allows for a scaffolded learning process where the faculty can build complexity into the situation over time. Now, as a certified healthcare simulation educator, simulation is my personal favorite. Although simulation can only be counted as indirect patient care hours, it prepares students to be able to meet minimal competencies before they enter that clinical setting and have to demonstrate competence in a high stakes environment. And simulations created using the AACN standards indicate how formative assessment and simulation can provide ongoing feedback to identify gaps and enhance learning. Simulation is also a repeatable, consistent experience for all learners and allows for reality-based practice. Engaging with simulation as a learner group can enhance cooperation and provide that professional connection among learners. Finally, we know clinical experiences are not the same for every student. And with simulation, faculty can ensure students have experience with those low frequency but high risk events that a nurse practitioner needs to be able to recognize quickly and respond to appropriately. I want to address some best practices for the implementation and evaluation of competency-based curriculum. First, use Wiggins and McTeague's backward design to set your curriculum. Start with that end in mind, the outcomes you need your learners to achieve, and intentionally approach each component of your curriculum. Once program and course outcomes are identified, determine that acceptable evidence to measure the outcomes. And the essentials framework, resources from your accrediting body and professional organizations such as NOP provide guidance on measurement. And finally, plan learning experiences that help your students achieve those outcomes. Now, it's never over till you evaluate. Ensure that the measurement tools that you select are psychometrically sound, reliable, and valid. Direct observation by faculty ensures that the students completed the activity and used appropriate skills, critical thinking, and knowledge while performing that competency. Students need to understand how they'll be evaluated and on what criteria. Using rubrics provided to the student before completion of the competencies allow the students to understand expectations for competency completion. And rubrics with a range of score in which a 1 may be assigned to not met and a 4 is assigned to met allow students to see progression in their ability over time and is useful for determining growth and competency during multiple evaluation points. Now, met and unmet, useful, but they should be used only for critical skills or the end of semester, end of program evaluations to ensure that those competencies are being met. And feedback is critical. It's always critical and should highlight what the student is doing well so that those behaviors are retained for the future. And if a competency is not being met, the student needs to understand what skill, behavior, or knowledge needs to be improved, and they need to be provided with remediation opportunities to achieve success. And then if you do all these things, by the end of the program, all evaluations should demonstrate the evidence that the student has met all the competencies before requirement. Now, this is an example of a clinical evaluation framework that evaluates progressive learning and competency acquisition based on the PRIME model. Note, the model is leveled to evaluate progressive learning and see the modification of beginner stages of clinical competence, that novice, advanced, beginner competent, and proficient. Evaluation includes a programmatic assessment. Course level assessments are the pieces of the larger program assessment, so be sure to track the students' progress across courses and collaborate with your practice partners to see where shared assessments can be fitted into program outcomes. Here's some best practices for faculty to implement as the transition to competency-based education occurs. First, make sure, again, the competencies are visible for students. It needs to be clear what the student is expected to do. And then help students to develop personalized learning plans for their educational journey. Provide coaching to support success, progression, and accountability. And this does not have to fall on the faculty alone. Engage other representatives at your institution to coach students. Provide transparent policies related to what the process is if a student needs to retake an assessment, and outline policies that support that variable student pacing. Embracing CBE requires very transparent progression plans and policies. And finally, a robust and continuous quality monitoring process. When you try something new, it's so important to be vigilant in your monitoring to ensure you're providing the best learning experience for your students, which are the future nurse practitioners. And use your resources. There are many guides and toolkits that provide detailed information about competency-based education and nursing education. Now, I want to leave you with a final thought. I hope this presentation has provided you with some valuable information, but more than that, I hope it showed you that you already have knowledge, skills, and attitudes to transition to a competency-based curriculum at your institution. Remember to trust yourself. You know more than you think you do. The next few slides are the resources I used in this presentation. Now, I'd like to turn this over to Julie Montz. Julie is the Regional Medical Program Director for Kaplan North America and can share some ways Kaplan can assist you in the transition to CBE.
Thank you, Christy. Can you progress to my next slide? So I'm Julie Montz, and Kaplan can support competency-based education through developing students' diagnostic reasoning skills, providing clinical exposure, offering objective reporting, and aligning with the competencies. So to circle back to the ensuring nursing students are able to integrate and apply their knowledge in the context of a practical setting, Kaplan has resources that can help you with that. So starting off, we have iHuman Patients, which is a virtual simulation platform with an ever-growing library of cases that span the lifespan, diverse. You have various body systems, and we have cases in both hospital and clinic settings. iHuman allows students to really go through an organized approach of patient planning, from initial history taking all through writing a comprehensive written treatment plan. iHuman provides an avenue for students to really re-engage with material, and then they can really identify their individual knowledge gaps and areas of opportunity. They can get that clinical exposure to must-see diagnoses or just select diagnoses that they don't have the opportunity to necessarily see in person. And then iHuman also allows them to practice really consistently to master content and become proficient and in thinking more medically and just really gaining those skills. So in addition to iHuman Patients, we also just recently launched an FNP certification exam prep course. This prepares for both exams. It is everything that students will need. We did a lot of research and we're very excited because we really sat down with students, nursing students, to see what would help to make them successful. There's over 110 hours of videos that really address what's seen on exams, 500 plus question Q bank, over 700-page ebook flashcards, practice exams, and Kaplan exclusive micro virtual sims, which are short 15-minute engaging patient encounters. So that FMP course is fantastic. In addition to that, if you do have adult Giro nurse practitioner students, we also just recently launched a Q bank to help with those certification exams. So if any of this is intriguing to you and you would like to learn more, please reach out and to schedule a demo with us. You can find that information here on the slide. To reach out, it's ihuman.com, and we would love to show you our products and talk through more about them. So thank you.
Awesome. Thank you, Julie. I will now open it up for questions. Maria, did we have any questions that came in?
Yes, we had a couple of questions from another Maria. Are the progression indicators the same as the NONPF core behaviors?
Oh, that's a very good question. Progression indicators are a broader format to say this is what they need to achieve throughout the progression. The core behaviors are the ultimate goal. So progression indicators mean perhaps they learn to read a journal article. Say we're talking about research because Maria's talking. I hit me on research. If they learn to read an article and determine if it's sound and psychometrically valid. Well, when you progress to those core behaviors, then you will see not only can they read and determine that it's psychometrically sound, but they can interpret and incorporate the information from that journal article that they have determined is valid into their practice. So progression indicators start at a more basic level and get to those core behaviors that not incorporates being the deciding factor, shall we say.
Great, thank you, Christy. And the second question is from Mai, and they're asking, how is this physical assessment example differentiating level 1 and level 2 competencies?
That's a very good question, but when you look at physical assessment, it doesn't change whether you're a nurse or a nurse practitioner doing the actual assessment. The change is the level and scope of practice and what you do with that information. A nurse practitioner will do the same assessment, but they will take that information. They will define a differential diagnosis. They'll set up a treatment plan and they'll follow that patient all the way through the completion of their treatment. And so there are certain components. The level 1, all nurse practitioners have already met level 1. They have already gained that pre-licensure nursing RN license, so they have met those. But sometimes you have to repeat them again to show that you can build on that information, you can build on that assessment, and actually make those decisions that impact the patient's outcome.
Great, thank you. I see a couple more questions popping up now. There's a question about, are there any plans for a PMHNP review class?
You know, that's something we need to think about. I love that idea. I ask that you reach out to me, christy.doherty@kaplan.com, and let's chat about that. That would be excellent.
Great. And there's one more question for courses that do not include direct application, does that mean that application will have to be assessed in the clinical courses?
Yes, absolutely right. The competency is actually verified in that direct application clinical course. But here's the part that's the problem. We know that clinical sites are limited. They have short periods of time to demonstrate that they are competent in a certain area. And you need to make sure in that repeatable, frequent assessment that when students end up in that high stakes environment where they have to demonstrate that they are competent, that they have had the opportunity to practice in some indirect way to be ready for that high stakes clinical environment. So yes, it is challenging to some of the products we offer are indirect. but you want them to be able to come out and know that they will be able to meet that competency instead of having to rearrange another clinical site and find another preceptor or any of things like that that might be necessary.
And so it looks like Samira has a couple of follow-up questions. Is NCLEX and certification exams a direct or indirect assessment?
Standardized exams are considered indirect. So all standardized exams are indirect.
Yeah. And then she brought up especially with ethics, which is hard to come up in clinically. So I'm assuming she's saying that it's hard to assess, ethical behaviors in clinical practice.
Certainly, but that's where a simulation or a group discussion among colleagues, your nurse practitioner students would be very valuable to show. For example, you can set up, we did this when I was in school. A topic was brought up to the nurses, and you were assigned whether you were pro or whether you were con on this particular topic that had an ethical component to it. And regardless of your beliefs, you were to research and validate and provide a strong argument that supported the assigned category that you were in. And there was a group engagement. It was a way to collaborate with your colleagues that were assigned in the same category that you were, and then provide sound reasoning back and forth on what an ethical situation and the different perspectives that come up. So yeah, it's very hard to see that in clinically. And a lot of times nurses and nurse practitioners are put in that observation status where they can't really engage in an ethical decision as well. They just have to observe. But bringing it to the classroom or bringing it to the simulation where they get to do the direct decision making and they really get to think about what they would do in that situation is so vital for their professional education. So when they're out in the real world, they are prepared to at least, assess all of the information before they make a decision.
Great. And I think that's all the questions that I see for now. Does anyone have any other questions? That's it in the chat.
Okay, well, thank you everyone for attending. I'm going to pass it back to Anne in case she has any final words for us here. And we so appreciate your time taking out. We know everyone has a busy schedule. And so thank you so much for joining us for an hour here.
Thanks, everyone. Great work. And just again, the slides and recording will be available on Friday. I did put the link in the chat, and you'll also get a follow-up email with it. So thanks so much, Dr. Doherty, Dr. Ojeda, and thanks everyone for attending. Have a great week. Bye-bye, everyone.